Candidate 1.
Yes, doctor.
Case number 1. This is 55-year-old female patient presented with post-appendectomy pain.
Okay.
Go on. Go on.
Okay, I'm started to scroll. Okay, I'm presented with a CT scan of the abdomen with contrast for a female patient post-appendectomy. I scroll through the images and then I start to give my comment. Okay, I'm just trying to get to the first image of the study. Okay. Okay, I can appreciate that there is periportal edema and there is some dilated bowel loops at the middle of the abdomen. There is free fluid collection noted at the right iliac fossa. So I can appreciate that there is a localized area of fluid collection noted. I'm just tracing it to make sure it is not connected with the bowel. Okay, so I think this area is a localized fluid collection with enhancing wall. Okay, and regarding the dilated small bowel loops, I are likely reactive. I cannot find a transition zone or any abnormality in the hernial orifices. So I'm suspecting a post-appendectomy inflammatory changes. Now I will get back to the area of periportal edema to examine it. I can see there is a focal lesion in the liver. It shows nodular peripheral enhancement. I will review it in other sequences. It could be incidental hemangioma. Now I'm looking at the pancreas. As I can see, I can appreciate that there are some dilated bowel loops at the
Where?
at this area. So I think they are communicating with the bowel. Now looking at the stomach to find the relation to the stomach. Okay, in my routine practice, I will also examine this area in other orthogonal view in coronal or sagittal, if available. There is also some hypo-enhancement. No, not hypo-enhancement. Okay, it's fine. So can I check the sagittal, please?
Digital? Okay.
Yes. Okay, thank you. Okay. Um, so I'm suspecting the bowel loop seen at the upper part of the abdomen to be part of a paraduodenal hernia, and they are relatively hypo-enhancing with incidental hemangioma in the liver, with post-operative changes at the site of appendix, also raising suspicion of uh, uh, maybe infection if the patient has fever. So I'll convey my findings to the referring physician and recommend um, urgent referral to the surgical team.
So what's
Um,
your final diagnosis?
I'm suspecting internal hernia. Yes, paraduodenal internal hernia
Mm-hmm.
with the
Okay.
ischemic bowel. Yes.
What is the exact name of this type of hernia?
Um, um, right paraduodenal hernia.
Right paraneum. No. Check the axial again. Not
Okay.
here. Okay, it has a more specific name. Where exactly is the bowel located?
Um, um, First, I thought it's a lesser sac, Foreman Wenslow hernia, but I can
Yeah, you are
see.
correct. See,
Yes.
1 second. You are correct. Where is the
Okay.
bowel? In the lesser side. Okay. In the lesser
Yes.
side.
But
Okay.
I can see them anterior to the stomach mainly.
Are you sure? What is this?
Okay.
This is the stomach. Follow it. This is the stomach.
Okay.
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 So
So,
what's your final diagnosis?
okay. This is strangulated lesser sac internal hernia through foramen of Winslow. Need urgent surgical referral.
Okay. What else? What happened here for the liver? Have a look and tell me. Don't satisfy of search, please.
Okay.
Mm.
There's incidental hemangioma, I think, and there is periportal edema due to maybe compression of the portal vein. But I can still see it patent. Um, there is also area of hyper enhancement subcapsular at this area. Um, it could be.
Yes.
I'm not sure.
What?
I'm not sure. I
Which?
don't know.
Okay. Which phase?
This
What is
is
the name of it? Hmm.
portal venous because I can see contrast in the portal vein and or maybe late arterial because the IVC and the hepatic veins are not well seen. So it could be late arterial, early portovenous.
Mm. Okay. So what's
Um,
your final diagnosis?
Regarding the liver, I'm not sure.
Okay. At least, see what happened here. This is subcapsular. Okay.
It
With
could be
no mass
transient
effect.
hepatic.
Okay. What else?
Um,
What is this also?
could
Benign or
be.
malignant looking?
It looks. Uh, I think it's a hemangioma, but I check it in the arterial phase also.
Yes. Okay, what else happened? Look to the preportal area. What happened for it?
There is edema, periportal edema, yes.
Why? What is your explanation for this?
Compression of the portal vein by the hernia.
Okay. What is the relation between the appendectomy and this pathology? Do you have any explanation
Um,
why it happened? Is it is there are any association between this internal hernia and appendectomy? Look
um,
again, or give me explanation.
okay, okay. I will look again, yes.
In your mind, in your knowledge,
Yes.
do you think there may be any explanation or any occasion that post appendectomy internal hernia?
No,
When
I'm not
when
sure.
it occur? When it occur?
Internal hernias.
When it
Uh,
occur after appendectomy? When?
when it happens after appendectomy, I'm not sure. I
Okay,
don't know.
let's see here. One with associated appendectomy. Okay. Do you think I will give you the choice? If this is open surgery, this is open appendectomy. Look here at the right iliac fossa. Do you
Okay.
expect there are any scars? Look.
No, I cannot appreciate any score.
Okay. So
It's likely
how
laparoscopic
how
appendectomy.
yes, what is the association?
Um, they increase the pressure, they inflate air,
Yes,
increase the pressure, it made the bowel loop
yes,
hernia, the foramen
yes.
fluenza.
So any laparoscopic surgery is highly predisposing for internal hernia. Very common, my colleague. Like this, the discussion will be in in the exam, like this. Okay, my colleagues, and you must give explanations about what you are seeing in the exam. Thank you, doctor, so much. What happened here? I give here misleading looks like misleading history. So our colleagues concentrate, and most of us will do like this, concentrate here. Okay, but the pathology is completely in the lesser sac. What happened here? She saw some dilated bowel in ectopic position. Dilated bowel means intestinal obstruction. In ectopic position, inside the abdomen means internal hernia. Okay. If you told the examiner this is a lesser sac, he will be happy. Okay. Maybe right duodenal, maybe correct or not, I don't know. But the exact name here is a lesser sac. Why? The lesser sac is the space between the left loop and the stomach. Okay. The greater sac is behind and inferior to the stomach. Okay. Second point, there are very important sign and very important. Look here to this swirling of the vessels. This point. Look.
Okay.
The herniated bowel must be posterior to a vessel. This is the vessels and this is the herniated bowels. Must be one of the criteria of any internal hernia. It should be posterior to vessel. Number two, you did very well when you explain here. This is periportal edema due to compression of the herniated bowel. Here, because you have a limited study, you can give some suggestion. Doctor, it may be sad, transient hyperattenuation, it may be hemangioma, like this. But it looks like at least benign. The association between the any surgery and internal hernia. Okay, when it is done, it is done laparoscope. Thank you so much. Internal hernia through foramen Winslow or or lesser sick. Both diagnosis or both are correct names. Foramen of Winslow is foramen connecting lesser with greater sick. Thank you so much.
Okay.
Next candidate. Sorry. 1 second, my colleague. Candidate 2, are you ready?
Yes.
14-year-old male patient presented to your radiology department after motor car accident. Can you request control, please?
Yes.
Go on. Go on.
Okay. Just it's jumping. I'm present with anxiety of the brain. It's not scrolling. Okay. Presented with anxiety of the brain of a 14-year-old patient presented after a car accident. We'll scroll through the whole stack of images before giving my comment. This is non-contrast to scan. Okay, I'll go to the area of interest. Upon scrolling, I could see area of hyperdensity projecting within the splenium of corpus callosum, also within the right periventricular indication, with area of hypodensity surrounding it in keeping with edema, causing effacement of adjacent cortical sulci. No definite hydrocephalus is seen. I'll just look for any other areas of hemorrhage or other intraparenchymal hematomas. Some more hyperdensities are seen periventricular indication. So this is a case of trauma. So I would, in my routine practice, I would look at the bone window as well to exclude any other fractures. But considering the distribution of the hyperdense foci, I'm worried about this patient as he may be having diffuse axonal injury. So I would recommend urgent referral to the neurosurgical team, and I would recommend doing MRI with susceptibility weighted images to further confirm my diagnosis after
Which
looking
degree?
at the window.
Which degree?
So there appears to be hyperdensities within the gray-white matter junction as well, and within the splenium of corpus callosum. I would check the midbrain.
Yes.
Okay. There appears to be faint hyperdensity within the midbrain. It appears to be heterogeneous than normal, so I'm suspecting grade 3 diffuse axonal injury. However, I would like to further do an MRI with susceptibility weighted images because it's more accurate.
Okay. This is MRI.
Okay.
Scroll.
MRI of the same patient. It's not scrolling.
1 second. Scrolling.
Okay.
Go on.
This is a T1 sequence. Okay. The area of hyperdensity seen on CT appears to be hyperintense on T1, confirming the presence of blood, no evidence of hydrocephalus, no evidence of brain herniation. So I would recommend, again, looking at SWI sequence to further confirm the diagnosis of diffuse axonal injury and further characterize its grade.
What's your other differential diagnosis in this case?
In a case of trauma with hyperdensities, in this distribution, it's specific for diffuse axonal injury. It could happen as well with fat embolism, however, less likely because of the distribution. So I would confirm on SWI and diffusion.
Both of them has blooming artifact in SWI, and both of them may have especially the fat embolism diffusion weighted image section. How could you differentiate between both of them?
In fat embolism, the diffusion would be in the appearance of a star field pattern with diffuse scattered hyperdensities within the diffusion sequence. However, with the diffuse axonal injury, I'm expecting a more confined areas to be affected, like the spleen of corpus callosum, the midbrain, and gray-white matter junction. And with correlation of patient clinical as well, usually with diffuse axonal injury, the patient would be clinically unwell with the Glasgow Coma scale less than 3.
No, radiologically.
Okay.
Radiologically.
So it is a distribution of the foci and the star field pattern.
Very important. The distribution, very important. Yes. What else? Or could you describe me the distribution?
In fat embolism would be scattered areas in whole of the brain, giving the star field pattern.
Yes, but very important.
With diffuse axonal injury, it would be more confined to the white matter junction, spleen of corpus callosum, and the brainstem.
Yes, thank you so much. The distribution is very important. Besides the clinical picture, okay, that in fat embolism, the patient is fractured, has fracture, very important. Okay, but here the distribution is mainly at the corticomedullary junction and corpus callosum here, or the corpus callosum or the brainstem. It is best to be detected either by gradient, okay, or SWI. You forget these collections. So, these collections. Hello?
Yes.
Okay. What does it mean for you? These collections.
Could be related to fracture with subdural hematomas.
Yes. So the final diagnosis here, grade 3 diffuse axonal injury. The differential diagnosis in trauma case, we must rule out fat embolism. Thank you so much, doctor. Next candidate. Next candidate. Hello?
Yes, sir. Yes, sir.
Request control, please. Request control.
Okay, sir. Requested.
Okay. This patient presented with lower chest pain. Go on.
Okay, this is a frontal chest radiograph of a skeletal immature female patient. I can appreciate both the diaphragm are lying at the same level. Mostly the left hemidiaphragm is slightly raised, and I can also appreciate an area of lucency with thin margin and maybe airflow level along the left lower zone. And in addition, there is no cardiomediastinal shift. Heart is lying in the center. Both the lung parenchyma appear unremarkable. There are important finding that I can appreciate. There are multiple areas of hyperdensities involving the lower dorsal and the upper lumbar spine, which could represent um, a vertebroplasty. Maybe, and there's mild scoliosis of the lumbar spine as well, with convexity towards the left side, right side. I would like to know if there is any history of trauma in this patient.
Yes. Yes. Hello? Hello?
Hello, sorry, sir, I lost my connection. Can you hear me?
Okay. Yes, there are history from.
Yes, so I'm in this patient. I'm suspecting a diaphragmatic fracture on the left side, diaphragmatic rupture on the left side, with the herniation of the bowel content and maybe stomach into the lower chest. I would like to confirm it on the for the cross-sectional imaging. I would inform my findings to the clinical team, and I would recommend further contrast and CT of the chest and abdomen for confirmation of my finding, and to also look at the other associated injuries if they are present there. And I would also like to rule out any volvulus, gastric volvulus associated with the herniation. Okay. It's not scrolling. Okay. Okay, this is a post-contrast CT of the same patient. Um, it's not scrolling, sorry.
Second.
Sir, it's not scrolling. Can you scroll it for me?
Yeah, yeah, you can use the side bars or arrows.
Sorry. Okay, so this is axial sections, post contrast CT chest, soft tissue window.
Forever or not,
Uh,
I will scroll for you.
Scroll. Okay, so I can see. Yes, there is abnormal location of the bowel and stomach, which is lying higher than its usual level. Oh no, sir, it's very. Yeah, please. Thank you. Uh, I would confirm it on the coronal view. So on this coronal view, I can see there is a defect in the diaphragmatic outline on the along the lateral aspect, with herniation of the stomach, which is forming a typical hourglass pattern. And this is quite suspicious. I think I would like to look at the delayed images of portovenous phase to see if there is any compromise to the vascularity, or any development of any hypoperfusion, or development of ischemia, which is my prime concern. And I would urgently inform my findings to the clinical team, would refer the case to the surgical team for urgent management in this case.
Mhm.
Mm-hmm. Yes. Uh, yes, sir. This is. I think there's no enhancement on this abdominal scan. I can see the contrast in the aorta, but I cannot see any enhancement below the diaphragm.
But do you think in this very wide opening, maybe
Yes.
it's one associated with a skin, and compare the wall here with the rest of the pouch and the organs? Look here. Okay. Why you can't see enhancement in the bowel? Do you know why?
I have to look at the great vessels, branches, visible branches of the aorta, just to look at if there is any thrombosis. Uh, Sir, it's not scrolling again.
From this photo, from this section, why you Couldn't see any enhancement within the herniated bowel or the underlying bowel. Why?
This could be due to thrombosis of the vascular supply, or maybe a vascular
No, because
injury
this is
associated
pulmonary
with.
angio. See, because this is pulmonary angio. See, CT
Yes.
pulmonary angio. Here, this is pulmonary angio. You can't assess the bowel. Very easy. So I told you, please compare the herniated bowel with non-herniated. Compare the herniated bowel with the other organs. This is my advice for you. So what's your final diagnosis? This patient has trauma since four months.
Trauma for 4 months.
Yeah.
Okay,
So
so
what is your final diagnosis?
s- yes, yes. Usually, the diaphragmatic rupture, the patient presents late because sometimes defect is small, and with the passage of time, due to herniation of the bowel contents, it may get large, and it is possible that patient may present late after few months after the trauma. So the
Okay.
final
So
diagnosis
the diagnosis is delayed
is a
diaphragmatic
diaphragmatic rupture.
rupture. Thank you so much. Thank you. So the
Delayed
diagnosis here
diagnosis.
very important.
Thank you.
Delayed diaphragmatic rupture with herniated bowel or stomach. What happened here, doctor? Your style is amazing, and your answer is so ideal. Why? I give her the X-ray, and she spontaneously asked me about history of trauma. Like this, the examiner want from you. Why? Because in daily work in NHS or in anywhere, you may be presented with a case with incomplete history. You must search behind it. Okay, not just a
Yes.
herniation or not just assist whatever. Okay, you must search behind it. Is there are any trauma? This is very important. She won the case when she asked this question. Why? Because I told her yes, and she start to ask to have the right to ask for CT, and immediately I give her. Okay, my colleagues, very important, very important. Thank you so much.
Thank you, sir.
Next candidate,
Assalamu alaikum, sir. I'm candidate for.
Salam. Doctor, this is a 10-year-old female patient presented with seizures. Can you request control, please?
Yes, sir. Please, I'll request for control.
Go on.
Yes. I've been presented with MRI T1 axial sequence of a 10-year-old patient. I'll take a moment to scroll through the images and then would start presenting my findings. Okay. So in my initial scroll, I could appreciate there is no hydrocephalus, no midline shift. I could appreciate subtle uh, of the left-sided temporoparietal gyri without any significant or appreciable vasogenic edema. The insular parenchyma also appears to be a bit prominent as compared to the right side, but I'll confirm these findings on the T2 as well as FLAIR images. I'm going to the I could not appreciate any crowding at the foramen magnum, so there is no inferior tonsillar herniation. No appreciable mass lien is noted. I'm looking at the, I'm trying to look at the sella.
Yes.
Yeah. The cellar region appears to be of hypointense signals. I would reconfirm it on the sagittal sequence as well. I would, thank you. So these are the sagittal sequences. Okay. So the brainstem parenchyma appears normal. The pituitary gland appears normal, lying within the cella. There is no expansion of the cella. However, the supracellular CSF, supracellular hyperintense signals are there are supracellular hyperintense signals which appear to displace the optic chiasma superiorly. Besides that, so I feel there is a supracellular T2 hyperintense abnormal signal area which is displacing the surrounding structure, especially the optic chiasma, and I would like to confirm it on diffusion weighted as well as post contrast images as well.
So do you remember the history?
10-year-old patient with seizures, sir.
So when you are presented with young patient with seizures,
yes,
what
sir.
are you searching about? What is your concern?
Sir, I would also like to rule out areas of hippocampus to rule out mesial temporal sclerosis in a young child.
Before going to the hippocampus, show me this region that you are describing in sagittal. Show me, please.
Sir, if I go in the midline, I feel there is yes, this area plus this.
This is the C. This is the CSF pulsation.
Yes, sir.
Okay.
Sir.
So which sequence do you want?
The flare.
Okay, which flare?
If flare coronal is available or T2 coronal, so that I can have a look at mesial hippocampal region.
Only axial.
Axial, sir. Okay. So these are the axial flare images. Okay, there's no supratentorial. I'll be going towards the temporal area, temporal lobes. There is subtle hyperintense signals on the right side in the medial temporal regions. Yes. On this, with some prominence of the yes. There is subtle signal abnormality on the right side with one flare hyperintensity as well as a few areas of abnormal signal area on the left side as well. Appearing flare hypointense, these can be since they are flare hypointense, these can be VR spaces, but on the right side, these areas are hyperintense. So I'll be concerned for this area. Also,
up here.
Yes, sir. There are abnormal signals within the right hippocampal region.
Yes.
So I have strong suspicion of mesial temporal sclerosis of the right side. I'm trying to look for any abnormal signals on the left side, but it appears to be a unilateral right-sided pathology. I'll convey my findings to the referring physician, and the patient needs to be on anti-epileptic medication for this pathology. And if refractory, the patient needs to be discussed in neurology MDT for further surgical management then.
Okay, but where is exactly the abnormal thing, please? Could you describe more?
Sir, over here, on the right side within the hippocampus in the right temporal lobe, this region appears abnormal.
Do you know the different parts of the hippocampus?
Different parts of hippocampus? No, sir.
Head,
Sorry. Cannot
head,
recall at this
head.
time.
Yeah, this is the head. Okay,
Sir,
head.
sir,
Yeah, okay, and body. See, it has also tail. Okay,
sir.
what else happen here besides the abnormal signal inside the campus? See, because this
Mild,
is in the
yes,
spot, so you must be more descriptive. There are
sir.
abnormal signals. What else?
Sir, mild widening prominence of the temporal horns because of the
Yes,
yes, because of the
yes,
sclerosis that has affected the parenchyma.
yes. And what else is the last criteria of typical mesial temporal sclerosis?
I should be looking at the GRE sequence for any blooming artifact to look for sclerosis.
If you look here, you will see some undulation, but here it is smooth, completely
Sir,
smooth,
sir.
correct?
Yes, sir. Yes, sir.
Laws, it named laws of the normal interdigitation. It is very, very subtle, but at least when you are sure you are presented with a case of temporal sclerosis, give as much as possible descriptive details. Okay, thank you so
Sir,
much. I will give
right, sir.
you, yeah, very small advice. Don't forget number one, the history. Number two, you suspect something here. Okay, here in the supracellular,
Yes, sir.
and
Sir.
almost you are thinking of the tuber cinerarium hamartoma, I think. Okay, uh, you ask for surgery. Okay, but still now you are not sure. Don't tell the examiner I see something here and start describing before excluding other most common causes of the complaint, like what? Like mesial temporal
Scissors.
sclerosis.
Right, sir.
So ask for flare. Okay, there are very obvious pathology here. So I will neglect the previous diagnosis
Mm, mm.
immediately. Why? All of us like this. I will neglect. And even in the real work, we sometimes do like this. Look here also, my colleagues, if you want one of the other criteria of the mesial temporal sclerosis, the fornix. This is the fornix. This is the fornix. Compare, there are difference or not.
Yes, sir.
Very important. Sometimes in our daily work, uh, we are searching for the fornix confirm our diagnosis because this case is very obvious signal abnormality here. Okay, but sometimes we didn't have clear MRI findings, so sometimes we compare, and there are some measurement like this. The fornix is atrophied on the ipsilateral side. Okay,
Mm. Yes, sir.
abnormal signal, reduced volume, absence of the normal interdigitation besides the fornix. And I think there are something related to mammillary body, but at least there are four I finding that prove mesial temporal sclerosis. Why mesial temporal sclerosis should be diagnosed when you are presented with? Because it is the only pathology or only underlying cause, and the most common, by the way, for epilepsy that can be treated surgically by lobectomy. Thank you, doctor,
Yes,
so
sir. Thank you
much.
so much, sir. Thank you so much.
Thank you. Right mesial temporal sclerosis. Okay. The patient has left-sided focal seizures. Okay. Thank you so much. Next candidate.
Yes, sir.
Who is coming? Request control, please.
Right, sir.
Request.
Requested.
This patient presented with dysphagia. Go on.
Okay, so I've been presented with one of the images of the barium swallow study. These are scrollable images, so I've been just going through the images first. So they are not scrolling, sir. I'm trying to. Images are not.
By the arrow, by the arrow. Use the arrow.
Oops. Yes. Okay. So I can see that there is passage of contrast is seen freely from the hypopharynx to the passing freely through the esophagus into the stomach. However, I cannot see normal peristalsis. There is slight indentation which is due to the aorta. As the patient is presented with dysphagia, so images are quite jumpy. I cannot. Okay, now I guess they are better. Or maybe at my place it's an internet issue, that's why it's jumpy. Okay, so I'm again going through the images just to check the cause of dysphagia. Okay, so there is no contrast retention within the esophagus. The contrast is just passed into the stomach, and there is no contrast extravasation. There is no diverticulum. I could not find any diverticulum, or there is no aspiration of contrast. Okay, so in the one of the image, I can see that there is slight contrast, a sliver of contrast is seen, which is extending medially. So I'm suspecting slight contrast extravasation at the gastroesophageal junction. So I will check.
Where?
So can you
Show
see
me.
my mouse? Can you
No?
see my mouse?
No, show me.
Okay, I think.
Right or left?
This is on the right side.
Where?
Sir, I'm pointing it, but I don't know why it's not showing to you.
Okay, leave the mouse. Leave the mouse. Here?
Okay.
Leave the leave.
Sir, it's not showing to me. I just give up the remote, then I can see, right? Okay.
Right or left side?
Sir, on right side.
Right side. See?
Yes. At
You
the
mean this side?
Oh, no,
Here?
sir. At the gastroesophageal junction.
Here? Don't worry about it. What else?
Okay. So I can see that there are few small filling defects are seen within at the just gastroesophageal junction. So I will confirm on the further to check the cause of this filling defect, as this is just transient or this is permanent. So I need to look the rest of the images again.
Doctor, look at this image before. What happened? Here. What happened here?
Okay, so I can see the contrast is aspirated into the both, which is more on the left side. So it may be
No
aspirated.
aspiration. What else? No aspiration. What else?
Okay, if it is not aspirated, then maybe there is any area of fistulous communication, which is causing this, as the patient have any history of carcinoma, which may indent
Where?
the
Where? Which area are you talking about?
so on the left side, just above
Where?
the
Upper, middle,
left
lower zone,
upper
esophagus,
zone,
upper
Where?
zone of the
Heart,
left
lung. Okay,
lung,
you
sir.
speaking about this area?
Yes, sir.
Okay, look, is this area changeable or fixed?
It's remained fixed. Yeah, it's not changing.
So it is related to contrast or not related to contrast?
No, then not related to contrast.
So what do you expect about it?
Okay, so it may be calcification, which is present. So I need
Okay,
to have checked the control images.
okay, no control image. What do you want to do for this patient? It may be calcification. What else?
Hello, am I audible?
Yeah, what else? What other differential?
The other differentials could be in this area, can be due to as the patients have dysphagia. So other possibility could be any abnormal vessels which is causing indentation
What do you want
of
to do for
the
this patient? What is your next step?
then CT chest with contrast. So CT chest with contrast to look for the presence of any abnormal vessel.
What do you think?
I'm just requesting remote.
Scan.
Okay, so in the provided lung window, I can see there is a soft tissue density area with lobulated margin is seen, which is involving the left. It is showing lobulated margin, so it is merges with the mediastinum, so it may be a mediastinal mass. So I will further evaluate. I'm looking for the rest of the lung. There is no further pathology in the rest of the lung, so I will further evaluate this patient on soft tissue window.
What do you think? Give me differential diagnosis before you shift.
Okay, so this can be due to any mediastinal mass like lymphoma or germ cell tumor, as it is most likely a mediastinal mass, or if the patient is young, so this can be a germ cell tumor. If the patient is old, so this can be a
Look at
lymphoma.
the angle. 1 second, 1 second. This is acute or obtuse angle.
These are obtuse angle.
This angle, acute or
No,
obtuse angle.
this is acute. Anterior one is obtuse.
This angle is acute, correct?
Yes, yes, sir.
So this is mediastinal or lung mass.
Yeah, then it can be a lung mass.
Okay, number 2. Look at the lung itself. Is this healthy lung?
No, I can see that there is interlobular septal thickening with few
Yes.
crown brass areas. Yeah, so interlobular septal thickening. So this can be due
So,
to lymphangitis carcinomatosis.
okay, look here. What do you think?
Yeah, so yeah,
Scroll, please.
okay.
Tell me, please.
Okay, so there is a mass which is present along the left main bronchus, causing its obliteration. It is causing mass effect over the adjacent vessels. So this is most likely a lung carcinoma with which is extending medially till the carina. So it is also involving the esophagus and causing pressure effect over the esophagus and dysphagia, I guess. Yeah, here is causing
What else?
significant obliteration.
What else?
So I'm looking for the presence of any lymphadenopathy, which is associated with
No. See.
okay.
Please scroll,
Yeah,
scroll, and describe. Give me more information.
okay. So I'm just going to check the vessels. So superiorly, this mass is having indistinct border with the aortic arch. And it is medially extending till the left paratracheal region. Now I'm looking for the involvement of the vessels. It is causing complete encasement and obliteration of the left pulmonary artery.
Mhm.
And
And okay, so images are little jumpy, so I'm having problem to scroll the images. Okay, so it is partially encasing the descending aorta and medially reaching till the left border of the carina and also partially encasing the esophagus. So I'm just trying to check for the presence of any collateralization as it is causing.
Yes.
So
What's your final diagnosis?
So as I can see, there is almost complete obliteration of the lumen of the esophagus. So this is lung carcinoma, which is locally invading the major vessels and causing compression over the or pressure effect over the esophagus. So I will convey the finding to the referring physician, and discussion in lung MDT for further management is needed in this case for tissue diagnosis and for further management.
How could they do which route? Through which route they can do tissue diagnosis?
By bronchoscopy, as this is central mass and it is in close relation to the left main bronchus.
Why is this patient presented with this patient?
Why this patient presented with?
Dysphagia.
This is most likely due to pressure effect, I guess.
Where? Where? Show me. Scroll and show me why.
Okay. I guess the images are quite jumpy, so I'm having problem.
One
Yeah, here
second,
I
I will
can
help
see that
you.
it is, yeah, just at the posterior to the left main bronchus. It is also having indistinct fat planes with the esophagus.
No. Where is the esophagus here? Go down, please.
Here, so
I will scroll for you and you should stop me.
okay,
Hmm.
this one, yeah,
Here?
yeah. So can you see my mouse?
Yeah, okay. Great.
Yeah, this
Thank you.
one.
What is the most important next step you will recommend after in your report?
So next step in this case is esophagoduodenoscopy, esophagoscopy to uh, check but it is lung carcinoma, so then bronchoscopy is advised, and as patient have
Before
um,
bronchoscopy. Before bronchoscopy. Look at the
uh,
image and tell me, please.
as the patient have completely encasement of the left main pulmonary artery, so
Yes.
intervention radiologists or vascular surgeons should be informed of these findings and further management.
Okay. You may use a stent.
Yes.
Yeah. It is very important to save this pulmonary. Thank you, doctor, so much.
Thank you, sir.
One exam scenario. Take care, my colleague. What happened here? Leave the mouse. What
Yes, sir.
happened here? Very misleading complaint. Okay? And most of us will concentrate in the perium. Okay? On the perium. Okay? As I advised the previous candidate, don't tell any diagnosis before either you are very sure or you exclude others. Here, if you look, the barium column is run from the top down very smoothly, superior and in the lateral flow. So, search for another tricky point or search for another diagnosis. In any barium or any chest or any shoulder, we should have a look for the lung, either for pneumothorax or mass. Very clear, pneumothorax or mass. Here we find something. Start from the beginning. Consider this one is like the control one, because this image contains the least concentration of value. Okay, there are opacity here. At least tell the examiner there are opacity. Okay, my diagnosis may be lung carcinoma or infection, whatever. I wanted to do CT. Okay, and this is, by the way, not calcification. Why? Because if you look inside it, first of all, the density is not dense like bone or calcium. Second, it contains some air inside. It even if this calcification it will obscure everything. This is the CT. Okay, you don't know what it is. This is mediastinal or lung. You can use white dark curves, doctor. This is a pulmonary mass centered on the left upper mediastinum. Okay, you don't know, or you are not sure either this is pulmonary or this is mediastinal. Use general terms. Despite there are acute angle here, okay, and you should at least tell the examiner there are acute angle. It may be pulmonary or mediastinal, but due to this acute angle, and the lung here looks like a smoker lung. See, there are hyperinflation beside. There are, if you concentrate, locular like emphysema. If you look here, this is barrel. See, barrel like lung hyperinflation increased the EP. It will not be like in the textbook exactly. You will see everything, but generally it is unhealthy lung. Okay, the smoker lung. We should be familiar with the smoker lung. You did very well when you talk about this lymphangitis carcinomatosis. Then I give you this one. Okay, describe as much as possible, and they give whatever possible of differential diagnosis. I think mass like this, completely encasing and compressing the left pulmonary artery, is a malignant mass. Okay, and associated with lymphangitis carcinomatosa, we are in the side of lung cancer more than mediastinal mass. Which mediastinal mass have this very aggressive criteria? Lymphoma? No. Thymoma should be more anteriorly. Okay. So,
Yes, sir.
we are talking about the most probable and the most likely. Besides that, see, it is completely surrounding the right main bronchus and extending, compressing and abutting the esophagus. And this is the cause of dysphagia. Okay. So it is almost, my diagnosis is almost a lung mass, a lung carcinoma. For number one, urgent interventional or cardiovascular interventional consultation to save this pulmonary artery. Left one. Second, transferring the patient to chest MDTs. And why? Number one, I will recommend for PET-CT before taking a biopsy. Why? Because all of this mass is not viable. Some of this mass is viable and some non-viable or show cystic changes. PET-CT targeted the biopsy. What does it mean? Directed the site or mapping the site of maximum SUV. So you can choose the best site for biopsy. And for your knowledge, my colleague, we always take, as a general rule in biopsy, we always take the biopsy from the periphery because most of the centers are necrotic. Okay, my colleagues, PET-CT is very important in all lung cancer because it is targeted the biopsy. make it more accurate.
Mm.
So it is lung cancer detected in Pariam soil. This patient was long-standing smoker, but don't expect from the examiner he will tell you a very helpful history. Thank you so much.
Okay.
Next candidate.
Thank you, sir.
Welcome.
Assalamu alaikum, sir.
Salam. Doctor, request control.
Requested, sir.
One second. Sorry. Go on, doctor. This
CT
is
scan,
young
axial,
child presented with abdominal distension. Go on.
okay. CT scan, axial images with contrast in photovenous phase of a younger child presented with abdominal distension. I am scrolling the images from lower cut to the uppermost cut. The striking abnormality on this soft tissue window, there is thrombus extending up to the right atrium, um, coming down in the IVC and the right uh, likely renal vein, and there is a large hypo-enhancing tumor uh, uh, filling the right renal sinus and destroying almost all uh, of the renal pelvis and lower lower pole and interpolar region. No macroscopic fat or calcification in it. I can see there are a few pathologically enlarged rounded retroperitoneal lymph nodes are there. I think right adrenal gland is uh, separate from the lesion. Left kidney is normal. Apart from that, mild right pleural and pericardial effusion, no left-sided pleural effusion. There is a pleural base nodule on right basal side. I want to see the lung window. And apart from that, there is um, uh, periportal edema and hypo-enhancement in the lung porta hepatis along the bile ducts, and no focal hepatic lesion, mild cholecystic fluid, and there is mild abdominal ascites. I am looking for any peritoneal mass. Uh, so, in summary, I want to see the bones on sagittal uh, reformatted images, if available. Otherwise, to me, in summary, there is a large infiltrative right renal tumor extending through the right renal vein into the IVC up to the right atrium with pleural effusion, and ascites. So right renal mass, likely renal cell carcinoma, and I will further discuss this case in the urology MGT.
Do you remember the
Uh,
history?
yes, abdominal distension, young,
For
young,
young,
young, yes,
young child. So what's
yes.
your final diagnosis?
Uh,
Young child.
yes, some renal cell tumors, like
What is the most common cause of young child renal tumor?
uh, in children, Wilms tumor are most common,
Yes.
um,
So
but
what's your final
uh,
diagnosis?
Wilms tumor are usually not causing so much vascular thrombosis. That's why I am thinking um, different from the Wilms tumor. However, this is also in pediatric age group most common malignant renal tumor is uh, Wilms tumor.
Okay. So what your final diagnosis is Wilms tumor complicated by
Vascular thrombosis.
and there are something important.
Yeah, right atrial uh, thrombus, which
Yeah,
need
extension. And
yes,
what happened? What happened for the liver? What is the name of this appearance?
nutmeg liver appearance, and can be
What does it mean?
secondary Budd-Chiari syndrome.
Secondary what?
uh, Secondary due to IVC thrombosis, hepatic venous outflow obstruction leading to this
So
appearance.
this is Budd-Chiari. Yeah,
Budd-Chiari.
yeah. This is Budd-Chiari. Whatever the cause, this appearance is Budd-Chiari.
No, no,
Either vena
appearance is known
occlusus.
as not nutmeg appearance.
Why? Why? This is
Nutmeg.
dirty liver appearance. Very dirty. Complete obstruction of the inferior vena cava. Okay.
Yes,
At least this is the appearance of the thrombosis of the liver, of the hepatic veins and the inferior vena cava. Are you agree with
yes,
me? We can call it Budd-Chiari or not?
yes, yes, sir. You can.
Okay. There are
Yes.
many names, nutmeg appearance, dirty liver appearance. At least tell the examiner something about the list. Okay.
Yes.
This
Thank
do
you,
you
sir.
think this patient is operable or inoperable?
No, this patient is radiologically, this patient is not preferable for both the conditions, for Budd-Chiari syndrome
Why
as
not?
well as
Why not operable? Why?
a tumor thrombus is extending into the
Are you sure this is true?
it.
Are you sure this is tumor thrombus? It may
Yes.
be plain thrombus. So why this
No,
is
this
tumor
is.
thrombus?
No, sir. The differentiation between tumor thrombus and bland
Yes.
thrombus is on this scan, the tumor is causing distension and having heterogeneous appearance and of the thrombus uh, pointing towards malignancy, and its characteristics are also
What
similar to
else?
the primary tumor.
Yes, this is most important. It enhances. Look, the
Yes,
thrombus is exactly enhanced in the same and exactly heterogeneous like the original tumor. So it is
yes, sir.
100% tumoral rather than plain thrombus. This patient, by the way, is inoperable, sure. And this is the role of MRI. This patient, when it is discovered in CT, they shifted it to MRI to rule out or to differentiate between tumor versus plain thrombus. Thank you, doctor, so much. It was a Wilms tumor. Wilms tumor. Okay, very important.
Thank you, sir.
See, here he mentions that it looks like renal cell carcinoma, but finally, the patient is very young, very, very young. Okay, thank you so much. Next candidate,
Hello.
welcome. Yes.
Okay.
By the way, the last case is typical long case scenario. Very typical. Okay. And even the case of the lung cancer, very typical. Long case scenario. Thank you so much, our colleague. This patient presented with abdominal pain. Go on.
Okay, so I'm presented with a CT with contrast. I'm just gonna scroll from the first to the last image before giving my comment. Okay, so this is the last. Okay. Sorry, I'm struggling just with the scrolling. It's just taking a lot of time. But yeah, so having a look to the abdomen, this is a CT with contrast. I did notice there is an extraluminal air seen here, and it's seen at the upper cut of the abdomen. This is likely a pneumoperitoneum, and also I will confirm it by looking at the lung view. I'm trying to see where is the origin of this pneumoperitoneum, because it means there is a hollow viscous perforation. Okay, so okay, so there's also a free fluid, intra-abdominal fluid extending all over the abdomen. I'm just gonna go up to the uppercut, since I did notice there was like fat stranding and congestion seen mainly at the uppercuts of the abdomen. Okay. Okay, so the pneumoperitoneum seem also to extend to the falciform ligaments, which sometimes denote that it's mainly it could be due to like peptic ulcer perforation. So I'm just gonna have a look further into the stomach and to see if there is any defect within the stomach wall. Mm. Okay, I'm suspecting that at this site there is like this small defect within the stomach
Where?
wall at this site. Here it is. Yes.
Where?
And I'm suspecting also, yeah. So I can see this one, and I can see also another one seen here also at this site, at the sides of the pylorus. So so all of this findings is keeping with perforated peptic, likely peptic ulcer with a pneumoperitoneum and a free fluid. This is an emergency finding. I would call the referral, and this patient need an urgent surgical review. I will also have a further look at the lower chest as well as the bone scans just to complete my study. And this patient will need an urgent surgical opinion and surgical management as well, which is likely going to be a surgical laparotomy.
Okay. Thank you, doctor, so much.
Thank you.
What happened here? We suspect at this area, which is a pylorus or the duodenal cavity. It's better to include both if you are not sure, because
Okay.
almost the perforation site is at the first part of the duodenum or the duodenal, what called duodenal cavity, where this see here. Okay.
Okay. Yeah.
As usual, there are large amount of free fluid and intraperitoneal gases, pneumoperitoneum. The
Mhm.
case is an emergency. Thank you, doctor, so much.
Thank you.
Last case, last candidate.
Yes, sir.
Request control, please. Request control.
Requested.
Yeah, go on.
Okay. I presented with a non-contrast study or a CT scan of the abdomen axial cuts. I'll scroll first, then start to convey my finding. Okay, I'm looking at the liver and at both kidneys. Looking at bowel, retroperitoneum, bones, and go to the pelvis. See the renal bladder also. Okay. So while I'm scrolling, I can detect the abnormality seen within the both kidneys. So I will go to the area of the kidneys. I can see the right kidney is a seat of large heterogeneous, it shows multiple fiber-dense stones with marked dilatation of the renal calyces. Um, uh, I'm trying to find any association of the stone. It is not staghorn stones. This is scattered through the calyces of the kidney. The left kidney also appears small size, showing multiple stones. Uh, Along this non-contrast study, I couldn't appreciate any free fluid collection. Um, However, I can see there is some soft tissue component seen within the right kidney of the dilated calyces or cystic lesions. Um, I correlate with the patient history, and in my routine practice, I will check the post-contrast study to see any enhanced mass.
What do you think about this finding?
I feel it is some obstruction of the right renal system, causing multi-calyceal dilatation.
What is?
I couldn't appreciate any staghorn stone, but I'm looking at the ureter. I couldn't appreciate right ureter.
One second. Look, yes.
Okay. Maybe this stone is a obstructing stone, central stone. So I'm expecting this obstructing stone causing marked dilatation of the right pelvic calyceal system and may produce xanthogranulomatous pyelonephritis. So, my routine practice, I'll check the post-contrast study to
Sure?
better.
One second. Are you sure? You will request for this patient post-contrast study, yes or no?
After checking the renal function, I have to request if the patient renal function normal, or I will proceed to contrast. If not,
Do
I
you
will.
think do you think this patient will have a normal renal function?
No. So I have to proceed for MRI.
Okay, the MRI. Go on.
Okay. I presented with coronal T2 MRI sequence with PET-CT. I can see there is diffuse enlargement of the right renal calyceal system with some areas of low signal intensity seen, and it is extending to the renal pelvis. So I want to look for the post-contrast study to see any abnormal pattern of enhancement of this soft tissue extending to the renal pelvis.
Why you insist? Why you insist for contrast? The both kidney are very diseased, and
Oh,
I discussed you and stopped you. The examiner will not do like this. Why?
yes, yes.
Okay.
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 So I have to see other sequences like uh, um, in phase or and out of phase to see any fat separation. Yes, already.
What else? Out phase and in phase will not help you. What else? Give me
Okay.
some differential, please.
For this, I might be maybe obstructing stone causing xanthogranulomatosis pyelonephritis of the right kidney.
Yes.
Second possibility may be, but less likely, invasive urothelial mass involving the right renal pelvis and causing obstruction. But as regarding the finding of the CT regarding multiple stones and one central stones, my first possibility for this case will go with xanthogranulomatosis pyelonephritis.
Mhm.
I think we
Okay.
may do a heavy T2 sequence and give us appearance of
Diffusion. If even diffusion, see, what do you think about these masses in diffusion?
there is some hyper intensity, so I correlate with
No,
ADC.
no, masses.
Okay,
See. Yeah,
is
the
there
mass, see,
restriction?
some
There is some
restriction. Yeah.
Yes, yes.
Okay. So
So
they did a biopsy. Till now, you are very great. Okay. Because we can't give the patient contrast. They give the patient take biopsy, and it was proven that it was xanthogranulomas. Why should xanthogranulomatous pyelonephritis be included as a first possible differential diagnosis due to this one, this
yes,
obstructing, and this patient looks like a stone buster. Why? Look at the left side.
left kidney show multiple.
Yeah,
Yes.
atrophic, multiple, and even the right. Okay, so
Yeah, بص about xanthogranulomatosis, يعني it is should be fat containing or not.
one second. This is obstructing, not a small stone. Associated with this appearance, you should both xanthogranulomatous pyelonephritis as a first and RCC as a second. Why?
Yes.
Why? Because we don't know. We don't have contrast. We don't have the typical appearance either for the xanthogranulomatous or the RCC. Okay, and if you didn't include, it may be a mistake. Why? Because you have some criteria, 50% at least of the xanthogranulomatous pyelonephritis. Okay, that is
Okay.
why we should include it. See here, the patient underwent surgical excision.
Yes.
Overall, and microscopically, it improved to be xanthogranulomatous pyelonephritis. Why? Because overall, this is non-functioning kidney and source of infection. And besides that, I think xanthogranulomatous pyelonephritis may cause other complications. See here, you must both RCC or renal abscess or tuberculosis in the differential diagnosis with zensogranulomatous, but at least you don't have the other criteria of abscess or TB, and this obstructing stone is very, very suggestive. I don't know if zensogranulomatous may lead to carcinomatous changes or not, but at least it is a very bad source of infection. Anyway, the moral from this case to be logic, to be more wider when you are enumerating your differential, especially when you find something suggestive. Okay, my colleagues,
Okay, boss.
any question?
Thank you so much.
Welcome.
Thank you, Dr. Rami. In fact, all
Welcome.
of us would like to say so much thank you for you. You make a lot of effort, dedication. You are always selecting cases very nicely, leading very useful discussion, theoretical points, and everything was perfect. You are doing this for us and for the batch before and for the batch coming. So thank you so much for everything you did for us. Thank you.